Good morning, ladies and gentlemen. The topic of today's lecture is the diseases of nails. You all know that nail is a very important part of dermatology or skin. And nail has certain features that are typical of this structure, which is different from rest of the skin. You can see in this diagram that the nail comprises of a nail plate and underlying nail bed. Nail plate is actually a continuation of stratum corneum, which we see in rest of the skin. The nail bed is seen, a portion of nail bed is seen beneath the nail plate, and a continuation of nail bed proximally is the nail matrix. The typical feature of nail is that the nail grows from the multiplication of cells within the matrix. And these cells of the matrix give rise to the nail plate. This is another view of the structure of the nail. There is a white portion proximally and a pink portion distally. The pink portion comprises of most of the nail, while the proximal white portion is just 1/5 or 1/4 of the portion of a nail, and this portion is called as the linula. The nail is attached to the proximal nail fold by a thin transparent layer, which is called as the cuticle. So on each side, the fold of the skin that attaches to the nail is called as the nail fold, like a posterior nail fold or the lateral nail fold. The matrix lies beneath the linula and beneath the proximal nail fold. Beneath the nail bed, then there are the ligaments and then the bone. Nail has several distinct anatomical areas. The hard nail plate emerges from the matrix of specialized epithelial cells. Matrix begins 7 to 8 mm under the proximal nail fold, and its distal end is the white crescent called as the linula. That is what I have told you before. The richly vascularized nail bed lies directly beneath the plate and provides adherence and support and is the basis of the characteristic pink color of the nail. The proximal and lateral nail folds surround the plate on the 3 sides. The cuticle is an outgrowth of proximal fold that provides a seal between the fold and the nail plate. So this is the proximal nail fold, this is the cuticle, this is the linula. Loss of cuticle in patients who use soaps and detergents frequently results in paronychia. And the nail is attached to the distal end of the nail plate is attached to the nail bed by onicodermal bands. And beneath the onicodermal bands is the white portion of the nail, which we usually cut. The normal distal nail, the field shows the junction of nail bed epithelium with hyponychium. The granular layer is present in the hyponychial epithelium, but not in the nail bed epithelium. The proximal nail, this is the proximal nail groove. Note that the nail fold, matrix, plate, and the nail bed. So this is the nail bed epithelium. This is the matrix epithelium. This is the proximal nail fold. So you can see in this picture that the cells of the matrix, they give to the dorsal, intermediate, and the ventral portion of the nail plate. And you should also clear your misconception that the nail plate contains calcium. So since the nail plate originates from the matrix and It replaces the stratum corneum of the skin. So the nail plate is mainly proteins and not calcium. Linear nail growth. Fingernails grow approximately 1 centimeter every 3 months. And toenails at 1/3 of this rate. Factors affecting the nail growth. The nail grows faster at daytime, during pregnancy, on right hand nails compared to the left. Youth and in fingers, the growth is faster. In summers, the nail growth is faster. Middle, ring, and index finger grows faster as compared to thumb and little finger. In male gender, the nail growth is faster. And if there is minor trauma or nail biting, then the nail growth is faster. And the opposites are for slower nail growth, that is nighttime, early life, left hand nail, old age, toes nail, winter and cold environment, thumb and little finger, and female gender. Nail grows faster in psoriasis, in PRP, on atrietinate or retinoid therapy, in idiopathic onycolysis in women, bullous ichthyosiform erythroderma, hyperthyroidism, levodopa. Slower occur in fever, finger immobilization by use of immunosuppressives, denervation, poor nutrition, kwashiorkor, hypothyroidism, yellow nail syndrome. Nail signs and systemic diseases. First of all, we will be discussing abnormalities of nail shape. Clubbing. In clubbing, there is an increased transverse and longitudinal nail curvature. The transverse, this is the transverse nail curvature, and this is the longitudinal nail curvature. Excuse me. So both the nail curvatures are aggravated in patient of clubbing. And this is primarily because of hypertrophy of soft tissue components of the digit pulp. The Lovey-Bonds angle, that is an angle between the angle at the junction between the nail plate and the proximal nail fold, is normally less than 160 degree. This is altered to over 180 degree in clubbing. Usually this angle is less than 160 degree. But in clubbing, since the nail bulges, so the angle becomes 180 or more. Clubbing appeared to be related more to increased blood flow through vasodilated plexus of nail unit vasculature. So the clubbing is associated with inflammatory bowel diseases, carcinoma of bronchus, cirrhosis liver, hemiplegic limbs, and subungual tumor when in a single digit. Koilonychia. In Greek, the koilo means hollow and hollow nails. Koilonychia, there is a concave dorsal aspect of the nail. Finger and toes are affected. The most common systemic association is with iron deficiency and hemochromatosis. In mechanics, softening of the nail with oil, and in hairdressers by permanent wave solution may also result in koilonychia. Then pincer nails, also called as the trumpet nails. Pincer nails describe a dystrophy in which there is an increased transverse curvature of the nail. So there is an increased curvature of the transverse curvature of this nail. It presents in 3 patterns. Probably the most common is associated with psoriasis. And pain may arise due to embedding of the pincer nails in the lateral nail fold and nail bed. So sometimes we have to remove this nail, particularly because of the complaint of pain due to pressure and wearing closed footwears. Macronychia and micronychia. Macronychia and micronychia are conditions where nail is considered too large or too small in comparison with other nails on the nearby digits. It is usually associated with an abnormal digit arising from underlying bony abnormalities, such as local gigantism caused by macronychia or megadactyly. Anonychia. Anonychia means absence of all or part of one or several nails. It can be congenital, acquired, or transient. Acquired forms are due to scarring of nail matrix arising from burns, surgery, or trauma, or due to inflammatory dermatosis like lichen planus. Similar scarring can occur in epidermolysis bullosa. So there is a congenital cause and acquired cause because of trauma or because of certain diseases, primarily lichen planus and epidermolysis bullosa, mainly the dystrophic variety. Then abnormalities of nail attachment. We have discussed the abnormalities of nail shape, now nail attachment. Nail shedding. Nails can be lost through different mechanisms. Complete loss of nail plate due to proximal nail separation, which is called as the onychomediasis. This may reflect a local or systemic disease. Local dermatosis such as bullous disorders and paronychia, for example, 10 or pustular psoriasis. Scarring of nail unit is seen in lichen planus and in 10. Trauma. For example, sports like football. It is also associated with subungual hemorrhage. Long-term athletes develop dystrophic nails, matching the history of recurrent shedding. Then temporary loss of nail may occur because of drugs, such as retinoids, large doses of cloxacin, and cephalosporins. Then Onikotosis Defluvium. It is described as a traumatic, familial, non-inflammatory nail loss. Inherited structural defect that is seen in epidermolysis bullosa. Nail degloving. This refers to partial or total avulsion, which is an end result of several insults to the nail like trauma, dermatological diseases, and drug reactions. Onicolysis. Onicolysis is distal and lateral separation of the nail plate from the nail bed. The area of separation appear white or yellow due to air beneath the nail and subsequent debris. The white color is mainly because of separation of the plate from the nail bed, and because of the air, the pink color of the nail bed is not reflected through the nail bed. There is a very important test which you should all remember to differentiate onycolysis from onychomycosis. And this test is called as the card test. You can insert your visiting card beneath the nail plate and above the nail bed. And if the card is clearly visible through the nail plate, then it is onycolysis, because the fungal infection of the nail always damages the nail plate, and the nail plate changes from being transparent to opaque. So if it is onychomycosis, and if you insert the card, then the card will not be visible because of opaqueness of the nail plate. So the card test will help you differentiate between onycolysis and onychomycosis, and will stop you in giving inadvertently the antifungal therapy to patients of onycolysis. Isolated islands of onycolysis present as oil spots or sabun patches a nail bed in patients of psoriasis. The common cause are primary idiopathic or secondary, which includes trauma, psoriasis, fungal infection, eczema, drug reactions, and photoonycolysis. So you can see here, there is a clear-cut demarcation between onycholysis and the attached nail. The attached nail is pink, onycholytic nail is transparent. But the nail plate does not seem to be damaged. Here, you can see the onycholysis at the distal end of the nail. And this is an oil drop sign, which we see in psoriasis, in which the onycholysis occur in middle of the nail plate and form of islands. And this is mainly because of separation of stratum corneum from the nail bed. Idiopathic onycholysis, overzealous manicure, frequent wetting, cosmetic solvents may be the cause. Maceration with water may also be a factor. Pain occurs only if there is further extension as a result of trauma or active infection supervenes. Most often, the onycholytic nail is colonized by Candida albicans, by some bacteria like Pseudomonas Pyogenia. And if the Candida is there, then you will have to, the nail fold will also be involved, and then you will be giving antifungal lotions as well as the oral antifungals. Pseudomonas Pyogenia will give a green color to the onycholytic nail. Onycholysis. The treatment of onycholysis, patient should be advised to cut away as much possible of loosened nail and to apply a topical steroid preparation containing broad spectrum antimicrobials that should be effective against both the yeast and a bacteria. So the better approach is using some mixed creams like Bacutin N or any other adequate mixture, along with some antibiotic or antifungal lotions like clindamycin lotion with the dermosporin lotion. The reattachment is slow. Some authorities still recommend 4% thymol in chloroform or Gentasyn eye drops for treatment of onycholysis. Secondary onycholysis occur in general medical conditions that results in impaired peripheral circulations and also seen in hypothyroidism, in hyperthyroidism, in hyperhidrosis, yellow nail, and shell nail syndrome. It is also seen by application of 5% 5-fluorouracil cream. Photoonycholysis occur during the treatment with sorelin, that is PUVA, by dimethyl chlorotetracycline and by doxycycline. Drugs like retinoids and cancer chemotherapy may also result in partial separation of nail or complete nail loss. This is photoonycholysis, which we see while patient is receiving PUVA therapy. Pterygium. The term pterygium describes the wing appearance achieved when a central fibrotic band divides a nail proximally into two. An inflammatory destructive process precedes the pterygium formation. So scarring of the nail bed occurs only when the process is destructive, involved, and damages the nail bed. The large pterygium may destroy the whole nail. The fibrotic band obstructs the normal nail growth. Most typically, it occurs in lichen planus in graft versus host disease. Also seen in leprosy and secondary to neuropathic damage. So you see this scarred portion that is dividing the nail, and in these fingers, you can see only the nail scarring as the nail plate is completely lost. Subungual hyperkeratosis. It entails the hyperkeratosis of the nail bed and hyponychia. Nail plate thickening is common. Due to excessive turnover of the nail bed, epithelium, and prevention of loss resulting in accumulation of squamous debris under the nail plate. This is seen in onychomycosis, in viral warts, in psoriasis, in PRP, Darius disease, and very typically in Norwegian scabies. You can see the squamous debris along with thickening of the nail plate. This is subungual hyperkeratosis. Nail thickening. Isolated thickening of nail plate is associated with yellow discoloration, as the nail blade vasculature is obscured by thickening of the nail plate. Common causes include psoriasis, eczema, trauma, and onychomycosis. Onychographosis describe thickened nails, usually of a great toe. It can be treated surgically by trimming with an electric drill, by chemical destruction with 40% urea paste, phenolization of matrix or carbon dioxide laser. You can see the onychographosis of big toe, but all the other nails also show thickening. Then changes in nail surface. Longitudinal grooves. Longitudinal grooves. The longitudinal grooves run in the longitudinal axis, as the name signifies. The medial canaliform dystrophy of Heller is the most distinctive form. This occurs centrally, and the nail is split in the midline with a fir tree-like appearance. Cuticle may be normal. This is an idiopathic disorder and cannot be treated with any topical or intralesional therapy. Some patients give history of trauma, or the disorder can be attributed to retinoids. You can see in this picture that there are longitudinal striations or lines on the nail. So this is because of repeated trauma and attributed to oral retinoids. And the treatment is unnecessary as the patient, as it is self-resolving, and patient should be advised to apply emollient cream to the nail fold. And one of the oil which is very effective to improve the surface changes in the nail is the almond oil. Onychorexis or brittle nail may occur when there are superficial grooves in nail that lead to distal splits. Again, this occurs because of inherently thin nail or by frequently wetting of the nails. So now we are discussing the transfer grooves of the nail or the Bue's line. Transfer grooves may be full or partial thickness. They arise when there is a temporary interference with nail formation and become visible on the nail surface. Transfer groove may be generalized, reflecting a systemic event like a drug reaction, a coronary thrombosis, measles, mumps, or pneumonia involving all the fingernails. The distance of groove from the nail fold is related to the time since the onset of the growth disturbance. Usually in a fingernail, the nail grows by 1 centimeter per month. So the distance of the Bue line from the proximal nail fold will determine the duration of the insult. Full thickness grooves can lead to nail loss called as onychometasis. This is a Bue line, which is the transverse groove in the nail. And you can see that the distance from the proximal nail fold is less than 1 centimeter. So it is possible that whatever the insult was, it was less than a month before. Then nail pitting. Pitting presents as punctate erosions in the nail surface. Individual pits may be shallow or deep with regular or irregular outlines. Individual pits of psoriasis are said to be less regular in form than those of alopecia areata. But this is not always the case. So if we classify the diseases with regular pits and irregular pits, then among the regular nail pits, alopecia areata will be on the top, and psoriasis pits are relatively irregular in size, shape, and distribution. Histologically, the pits resemble the focal areas of parakeratosis, that reflecting isolated nail malformation. The origin of pits means that they can be influenced by diseases in proximal nail fold, and thought that injection of triamcinolone in nail fold alone can suppress this. So nail pits can be treated by intramatrix Kennicott injection. You can see the nail pits. These nail pits are of irregular shape and size associated with onycholysis, and there is an oil drop sign here. So these are the psoriatic nails. So if you see the histology of the nail plate, these are the parakeratotic areas among the hyperkeratotic areas, and these parakeratotic columns are lost, resulting in nail pits. This is the high view or power view of the parakeratotic areas in the nail plate. Trachonychia. Trachonychia represents a rough surface affecting all the nail plates, and up to 20 nails are involved, also called as the 20 nail dystrophy. The main cause is alopecia areata, psoriasis, lichen planus, though most commonly it is an idiopathic disorder. Present as self-limiting condition in childhood or as more chronic problem in adulthood. There is some response to potent topical locally injected and systemic steroids, but this may be temporary. This is 20 nail dystrophy. The whole of the 20 nails are involved. The closest differential is alopecia areata. Onicochisia. Onicochisia is characterized by transverse splitting into layers of the nail plate at or near the free edge. It is reported in polycythemia, in HIV, and in glaucoma. Efforts at retaining hydration by wearing gloves, emollients, base coats, nail varnish may help reverse this clinical changes. Biotin has been used as a systemic therapy for brittle nails and for onychochisia, but the scientific evidence is weak. This is onychochisia. You can see the transverse splitting into layers of the free edge of the nail plate. Then changes in nail color. Exogenous pigmentation. It is easy to demonstrate by scraping the nail. The green pigment of Pseudomonas is associated with onycholysis, seen typically with this infection. Nail plate changes. Pigment is added in a form of melanin produced by the matrix melanocyte that produce a longitudinal, brown longitudinal streak called as the longitudinal melanonychia in the entire length of the nail. And the longitudinal melanonychia is just like junctional melanocytic nevus, benign junctional melanocytic nevus. As you can see, that the color of this strip is regular, and edges of this strip are also very regular. Whenever there is irregularity in the edges or irregularity in the color, or you can see a nodule formation or bleeding, then this is suspected to be a melanoma. Otherwise, a plain black strip of nail is not at all melanoma. This is actually the melanocytic nevus of the matrix. And the arrow identifies the pigment granules in the pig staining nail plate. So you can see this pigment is present in the nail plate as well. Then pigmentation of the nail occur by use of heavy metals, by some drugs like silver, disruption of normal nail plate by chemotherapy, by some poisons or trauma can result in white marks of true leukonychia. Nail bed changes. We have described subungual hyperkeratosis, or the incorporation of drugs like anti-malarial phenothiazines may result in change of the nail bed. The splinter hemorrhages resemble rupture of nail bed vessels. This is common in various autoimmune disorders. Cyanosis make the nail bed blue, and carbon monoxide poisoning make the nail bed bright red. True Likonikia. White discoloration of nail is attributed to matrix dysfunction. Inherited form called as total Likonikia, in which the nails are milky porcelain white. In subtotal Likonikia, proximal 2/3 are white and becoming pink distally. So this is total Likonikia. Transverse Likonikia. You can see the transverse white lines, which are called as the Mies line. It results from the use of chemotherapy, poisoning, or systemic infection. These Mies lines are 1 to 2 millimeter wide transverse band in arcuate form originating from the lanula. So these are Mies line, and these are punctate Likonikia. These are attributed to minor matrix trauma, for example, manicure, and is also seen in alopecia areata. Generally, these kind of punctate Likonikia should be ignored, and no treatment is to be advised to the patient, just reassurance. Apparent Likonikia. Nail bed pallor may be a non-specific sign of anemia, of edema, and of vascular impairment. Terry nail. In terry nail, there is white proximally and normal distally. You can see the proximal white and distal pink area. And this is attributed to cirrhosis, congestive cardiac failure, and adult onset diabetes mellitus. So such sign is an indication that patient should be investigated. Half nails. These are the half white and half pink nails. The half proximal is white, distal is a brown shape. This is seen in chronic renal failure and after chemotherapy. Then murex paired white bands. The murex in which H is silent, these bands are parallel to the lanula in the nail bed. You can see these bands, these murex white bands. They are commonly associated with hypoalbuminemia, and correction of which by albumin infusion reverse this sign. Color changes due to drugs. Yellow coloration of nail plate occurs because of tetracycline therapy. Bluish color is seen due to mapacarine, hydroxyurea, silver, and chloroquine. Fixed drug eruption, nail bed can be dark blue. Inorganic arsenic poisoning. Inorganic arsenic produce longitudinal bands of pigmentation or transfer white strip Mies strips along the nail. So it can produce both the longitudinal bands as well as transverse white bands. Yellow nail syndrome. Nails are yellow due to thickening. Lanula is obscured and increased transverse and longitudinal curvature and loss of cuticle. The feature is accompanied by lymphedema at one or more sites, respiratory and nasal sinus disease. The nail grow at the greatly reduced rate of 0.1 to 0.25 millimeter per week. And fingernails compared all the 20 nails may be involved. This is the typical yellow nail. You can see the increased nail curvature, yellow coloration, loss of cuticle, and the nail growth becomes very slow. It is associated with recurrent pleural effusions, by chronic bronchitis, by bronchiectasis, by malignant neoplasms, D-penicillamine therapy, and nephrotic syndrome. Red linula. Dotted red linula have been reported in psoriasis and alopecia areata. If it is present in a single digit, then it indicates the local disturbance of vascular flow, mainly because of a benign tumor. Longitudinal Erythronychia. Matrix epidermal diseases, most commonly lichen planus and derriere, produce longitudinal Erythronychia. Thin longitudinal red streaks may terminate at a free edge with a split. This is a Erythronychia, and it terminates at the free edge by a split. Splinter hemorrhages. Splinter hemorrhages represents the longitudinal hemorrhages in the nail bed. They are most frequently seen in the distal nail bed and on the fingers of the dominant hand. These are the splinter hemorrhages. In dermatology practice, they are often found in association with psoriasis, dermatitis, fungal infection of the nail, but most commonly psoriasis. Also seen in bacterial endocarditis and antiphospholipid syndrome. Unilateral splinter hemorrhages occur after arterial catheterization on the involved site. Then developmental abnormalities of the nail. Nail patella syndrome. It's an autosomal dominant disorder and mutation in beta-1 protein. Nails are grossly defective and thumbnails are most affected. In addition, patellas are small than normal and sometimes rudimentary, so the knees are unstable. There are other recorded features like hyperextension of the joints, skin laxity, hyperhidrosis, renal abnormalities, and open angle glaucoma. Pachyonychia congenita. Pachyonychia congenita type 1, which is Jackson-Lewandowski's type. It's an autosomal dominant genodermatosis in which hypertrophy of the nail occurs. The nails are usually normal at birth, but within months they become discolored and progressively thickened, and more so on hands than as compared to feet. There is palmar and plantar hyperkeratosis and warty skin lesions at big joints, and there is mouth and corneal dyskeratosis. So thickening of the nail, keratoderma, and leukokeratosis are the prominent feature of Pachyonychia congenita. In type 2, which is Jackson-Lawyer, nail thickening is less severe and keratosis is also less. But in addition, there are multiple epidermal cysts and sebacestomas. Hairs are also dry and lustless. Infection of nail and nail fold. The most common infection which we come across daily in the nail is onychomycosis. Onychomycosis is the invasion of nail plate by species of dermatophytes. Commonly, the dermatophytes affecting the nail are Trichophytum associated with, usually this onychomycosis is associated with Taenia pedis or Taenia manum. And mainly the fungi is Trichophytum mentagrophyte and interdigitale, caused by the same species which caused the above infection. The typical feature of onychomycosis is that the nails are involved asymmetrically, usually one to two nails on the in the hands and 1 to 2 nails on the feet. There are different types of onychomycosis. Distal and lateral subungual onychomycosis is the most common pattern. Whitish or yellowish discoloration of distal or lateral edge of the nail. Nail plate is thickened and cracked. If you insert a card here, the card will not be visible because of a thickening of the nail plate. Then proximal subungual onychomycosis. It is uncommon, and invasion of nail plate occur from posterior nail fold. Then superficial white onychomycosis, again is less common. Dorsal surface of nail plate is eroded in well circumscribed, powdery white patches away from the free edge, and it is not affecting the whole nail plate. Endonyx Oliphomicosis, the nail plate is not only damaged but is scarred, and pits and lamellar splits. Invasion occur from the top surface and penetrates deeply into the nail plate. Total dystrophic onychomycosis, complete and massive destruction of the whole nail plate. In onychomycosis, the fungal hyphae are seen within the nail plate. This can be seen by sending the nail plate for histopathology, and on PA stain, these hyphae becomes more obvious. You can see these hyphae in the nail plate. Onychomycosis can also occur because of Candida infection, but in such cases, In addition to the involvement of nail plate, the nail folds are also involved with onycholysis. Bacterial paronychia. Acute paronychia is usually due to staph infection. It results from the local injuries, split, splinter, or nail biting. The condition presents as painful swelling of the nail fold. If superficial, it can be drained by incision with number 11 scalpel without anesthesia. A broad spectrum antibiotic is preferred. Chronic paronychia. Chronic inflammatory dermatosis of the nail fold. It may be associated with infection and most commonly candidal infection. Wet cold hand predisposes, seen mainly in housewives, in domestic workers, cooks, and canteen workers. It begins with slight swelling at the base of one or more nail, which is not as tender as in acute paronychia. The cuticle is lost. You can see the cuticle is lost, and now the fluid and the soap or detergent containing fluid easily goes into the proximal nail fold, causing irritation and infection. There is complex relationship with Candida, which may be identified by swabs and scrapings. Treatment is first by keeping the hands dry, emollients and protection during the rough work, combination of topical steroids and antimicrobials, and attempting to clean out the nail fold with sharp instrument is not recommended because this will damage the nail more. Herpetic paronychia or herpetic vitiligo. It is due to primary inoculation of the herpes simplex virus and present as single or group blisters close to the nail. It is painful and takes about 3 weeks to resolve. And treatment is by oral acyclovir, famciclovir, or valcyclovir. HIV infection. The most common findings on the nail are clubbing, transverse lines, Onicochisia, Likonikia, and Longitudinal Melanoma. In addition, there are lower threshold of infections with dermatophytes, yeast, and human papillomavirus and herpes. Crusted scabies is more frequent with HIV infection. Nail psoriasis. We have discussed the various different findings of psoriasis while discussing the abnormalities of the nail shape, color, and nail bed. But now we will discuss all the nail findings in a patient of psoriasis. Nails are typically involved in 40% of psoriatic patients at any point of time. Nail psoriasis is associated with more extensive psoriasis of longer duration and patient with family history of psoriasis and with presence of psoriatic arthritis. Psoriasis affect the nail matrix. It can affect the nail bed and hyponychium. The nail bed, if the nail matrix is involved in psoriasis, then it presents as the pits, ridges, and grooves of the nail plate, because you know the nail matrix gave rise to the nail plate. So whatever the changes which we see in the nail plate will be because of the diseases or involvement of the nail matrix. That is pits, longitudinal ridges, and grooves, transverse grooves on the nail plate. Pitting is the most frequent change in psoriasis, and individual pits being uniform in size at about 1 millimeter. The nail bed diseases, if the nail bed is involved in psoriasis, it results in subungual onycholysis like oil drop, subungual hyperkeratosis, splinter hemorrhages, and distal onycholysis. Psoriasis. Here you can see the several pits and some onycholysis at the distal end of the nails. The nail shows excessive pitting and onycholysis, as well as subungual hyperkeratosis as well. This is onycholysis and a few pits in the nail. Splinter hemorrhages are due to the increased capillary prominence and fragility of the nail bed in patient of psoriasis. So this is subungual hyperkeratosis, this is distal onycholysis and oil drops, and these are pits. And you can see the psoriatic lesion on the proximal nail fold as well. Acropustulosis. This form of psoriasis involves the destructive pustulation of the nail unit. It presents as a part of pustular psoriasis. palmoplantar pustulosis, acrodermatitis continua of Helupio, and parakeratosis pustulosa, typically in young girls on isolated digits. The nail plate may be lifted by sterile pustules in the nail bed of the matrix. There is associated erythema and discomfort of the end of the digit. Acrodermatitis continua of Helupio can be very aggressive and result in repeated osteolysis and loss of toes and distal part of the fingers in addition to very early destruction of the nail. This is acrodermatitis continua of Helupio, resulting in total loss of nail and also narrowing of the tips of the digits. Subacute and chronic paronychia in psoriasis. Periungual involvement may be dramatic and inflammatory, giving rise to gross disruption of the nail matrix. Chronic psoriatic paronychia cause loss of nail cuticle. Treatment of nail psoriasis. Avoiding manicure, keeping the nails short, wearing gloves for wet work, avoiding direct exposure to solvent, and encouraging emollient use. The irregularities on the nail plate can be smoothened by use of the nail gels. Clobetasol propionate ointment may be used with or without occlusion and rubbed into the nail folds. Triamcinolone acetonide 10 mg per ml may be used by injection into the nail fold or the nail bed. Other treatment options for the nail psoriasis include topical vitamin D analogs, hand and foot puva, retinoids, systemic methotrexate, topical cyclosporin, 5-fluorouracil, 20% urea cream, superficial radiotherapy or electron beam therapy. Diarrheal disease. 96% patient of diarrheal disease will have a nail change. This mainly includes red or white longitudinal streak terminating in a V-shaped notch. In severe cases, nails are lost. Occasionally, marked thickening of nail plate occurs. You see the longitudinal streaks and the notching at the distal edge of the nail. Eczema and nail. No nail change is specific and diagnostic of eczema. However, a patient of eczema can have the nail thickening, can have pits, nail loss, transverse ridges or furrows, subungual hyperkeratosis, splinter hemorrhage, and onycolysis. But none of the findings, none of the changes are typical of eczema. Treatment. General hand care is important with avoidance of soap, irritants, wet work, and any identified cause. Protective gloves should be worn with copious emollient application. Potent topical steroids may be needed, sometimes with additional topical or systemic antimicrobial therapy, which should be rubbed around the nail folds. Lichen planus and nail. Lichen planus is also a very important disease that affects the nail and is affected in 10% of patients of lichen planus. The disease can involve the proximal nail fold with bluish-red discoloration. Nail plate changes include thinning, brittleness, and crumpling or fragmentation of the nail plate, accentuation of the surface longitudinal ridging, onychorexis and pterygium formation. You can see the longitudinal striations here and complete loss of the nail in lichen planus. And here there is no gross nail destruction and some little bit of scarring as well. 20 nail dystrophy, then as already explained, all the 20 nails are dystrophic and showing distinctive longitudinal striations. Pterygium formation by scarring of the nail bed originating from the proximal nail fold. Lichen planus is treated by potent topical steroids rubbed on the nail folds in active stages. Triamcinolone acetonide may be instilled into proximal nail fold with local anesthesia. Oral steroids up to 60 mg may be used to arrest severe scarring of the nail, scarring in nail lichen planus. Cyclosporin can be of benefit as well as a therapy. then tumors under or adjacent to the nail. The most common benign tumor affecting the nail bed is the viral wart. It involves the nail fold, pulp, and nail bed, causing longitudinal ridging on the nail plate and nail plate distortion and onycholysis. Erosion of the underlying bone has been reported. The viruses are human papilloma virus 1, 2, and 4. Nail biting and occupations such as butchers may predispose to warts. There are a wide range of available therapies that include topical salicylic acid paste or plaster in colloidal base by cryosurgery, bleomycin, cantharidin, imiquimod, curettage, and carbon dioxide laser and interferon. Fibrous tumor. Coinant tumor is associated with tuberous sclerosis and present at puberty as periungual fibroma. They are often multiple, large or small, elongated or nodular, and produce longitudinal grooves in the nail plate due to matrix compression. You can see these coinant tumors protruding from the nail fold. Histologically, the periungual fibroma, the dermis is expanded by dense fibrous nodules containing ectatic vessels. So this is basically a collagenoma. Acquired periungual fibrokeratomas are all benign asymptomatic fibromas with hyperkeratotic tip and narrow base arising in the periunguum, especially the proximal aspect of the matrix. Fibrous dermatofibroma or two fibroma present as smooth edge tumor in the periungual tissue. So this is periungual fibrokeratoma. You can see the thick hyperkeratosis and core of unremarkable dermis. Onychometricoma. Onychometricoma is a fibroma of the proximal nail fold closely associated with the matrix. The main features are those of altered nail, which becomes thickened with increased longitudinal ridges. The tumor has normal immunohistochemical markers of a benign fibroma, and treatment is by excision. Subungual exostosis. It is a benign bony outgrowth of terminal phalanx, found on great toe or rarely on a finger, in subject between 10 to 35 years. It's not clear whether trauma is the main or a contributory cause. Pain is the presenting symptoms, and treatment is removal of tumor by using bone nibbler or chisel. This is bony exostosis. You can see this exostosis, the bone arising from the proximal, from the distal phalanx. Periungual exostosis. Well-established examples show mature bony and fatty marrow. Enchondromas. Enchondroma is a cartilage tumor, which present as painful solitary tumor at the distal phalanx with clubbing, paronychia, nail thickening, discoloration, ridging, and elevation of nail. X-ray show loosened expansion of the distal phalanx with spotty calcification. Treatment is enucleation of the tumor and autologous cancellous bone grafting if required. Osteoid osteoma of distal phalanx presents as enlargement of entire digit tip in a young adult with thickening of the nail and clubbing. Tender tumor is palpated, characterized by swelling and causing nagging pain, which are relieved by NSAIDs. Surgical treatment is by en-bloc resection. Implantation epidermoid cyst may produce a gradual enlargement of tip of the digits with appearance of clubbing and pincer nail, sometimes history of previous trauma. Surgery is curative. Metastasis. Metastatic tumor present as inflammatory swelling at the tip of the digits. X-ray revealed osteolytic lesions, and systemic examination and investigation may be required to find the primary focus. And in 50% of the cases, the focus is in the lungs. Vascular tumors. Subungual glomus tumor is then characterized by an erythematous nodule deep to the linula and splitting of the free edge This is a painful tumor, and pain is spontaneous or evoked by minor trauma or temperature changes. Histology is definitive and treatment is by excision. The subungual glomus tumor is characterized by dilated blood vessels surrounded by cuboidal cells, which are the glomus cells. And these glomus cells are derived from a smooth muscle. So on immunohistochemistry, smooth muscle actin is ordered, which is strongly positive in these glomus cells. Pyogenic granuloma. There are benign eruptive hemangioma, which may involve the nail fold or be subungual. Mild penetrating injury, friction, or immobilization of digit is the cause. Other causes are retinoid, cyclosporin, cancer chemotherapy, and antiretroviral therapy for HIV. Pain and bleeding is the frequent complication, and usually clinically it is sufficient to diagnose, but if has a very typical histology, if the specimen is sent for H&E staining, treated by destructive therapy like cryotherapy, carbon dioxide laser, or surgical excision. This is a pyogenic granuloma. You can curettage it or cautery the base or cut it and cautery the bleeding points. Atriovenous abnormality, periungual or subungual arteriovenous tumors, cirrhoid aneurysms are firm bluish non-pulsatile nodules in the nail folds or penetrating the nail. Histology show thick-walled vascular channels and fibrous tissue boundaries. X-ray reveal aneurysm dilatation of terminal phalanx. Distal myxoid cyst. The myxoid cysts are common in fingers than in toes, and they contain clear gelatinous fluid and discharge spontaneously on minor trauma. You can see this cyst within the nail bed, non-encapsulated but filled with mucin. Within the dermis, and there is no epithelial lining, usually treated by excision. Subungual squamous cell carcinoma. These are the crusted tumors elevating the proximal nail fold, resulting in gross destruction of the nail. Warty tumor nodule. Then nodule formation with ulceration and scarring. Histology have a typical feature of dysplastic or malignant squamoid cells, which are infiltrating the deep dermis. Treatment is ideally by Mohs micrographic surgery, because in nails, there is very little tissue to play with. And if there is no evidence of bony involvement, and sometimes the distal amputation is required if the tumor is aggressive and involving the bone. Epithelioma caniculatum is a slow-growing, locally destructive, low-grade tumor originating from a viral wart and histologically related to SCC. It is typically found on the sole of the foot, but may involve periunguum and mucosal surfaces and other locations. On nail bed, the underlying nail is disrupted by onycholysis. Biopsy confirms the diagnosis, and Mohs micrographic surgery is the treatment. Subungual keratoacanthoma, typically painful, rapidly enlarging lesions that are solitary but maybe multiple. It forms in a form of a crater. Histology shows a crater, and underlying epidermis shows moderate degree of dysplasia, but there is no invasion of the basal plate, basal lamina. Treatment again with Mohs micrographic surgery or curettage. More aggressive therapy like amputation should not be done. Melanocytic lesions. We have discussed the benign melanocytic lesion, which is melanocytic bands, but malignant lesions are also seen. Longitudinal Melanoma. So dermoscopy can be helpful in assessment and distinguishing between the benign and malignant lesions. Malignant melanoma is of particular note if the pigment spreads onto the adjacent nail fold and digit pulp, which is called as the Hutchinson sign. And dermoscopic examination may help in the diagnosis again. Lentigo maligna is the common malignant melanoma which involve the nail and nail plate. Subungual melanoma, the spread of pigment into the nail fold. You can see this spread of pigment, and the nail is grossly destructive, and the pigmentation is variable, and there is a nodule formation, destruction of the nail plate, oozing blood, and so all the destructive and abnormal findings are there. So it cannot be diagnosed as a benign lesion. Histology will show the typical histology of an atypical melanocytes in the nail bed. So mostly the lentigo malignant melanoma, in which the melanocytes are spindle in shape with hyperchromatic vesicular nuclei. Traumatic nail disorders. It can be acute trauma from hematoma or digital amputation, nail bed laceration. Delayed trauma sometime by special sports or occupation. There is split of the nail and reduction in length of the nail bed, sometimes associated with pterygium formation. Hematomas are possible, and sometimes the hematomas are to be distinguished from melanoma. And hematoma arise within the matrix, will be incorporated in nail plate. Dermoscopy will resolve the issue. Treatment is only to relieve the pressure by puncturing the nail by hot pointed implement, hot pointed cautery, or by small electric drill. The nail biting is a common habit in which the nail plate is regularly destroyed by biting. The changes are subsequently because of the repeated trauma. Fingers are commonly affected. Nails are short with up to 50% of nail bed exposed. Surface changes include the splitting of the nail into layers or sandpaper effect, and nail may acquire a brown longitudinal streaks. Treatment is usually unsuccessful, and mainly the psychotherapy is required. Cures relies largely on the motivation of the patient. Local antiseptic and antimicrobial ointment may settle the infection, and sometimes antidepressant and behavioral therapy is required. Nail can be damaged by the nail manicure and several instruments, so these should be taken care of while treating the nail. And sometimes nail is damaged by footwear, resulting in onychographosis or nail hypertrophy, mostly seen in elderly. You can see this nail onychographosis, and treatment of onychographosis is radical or palliative. Radical include surgical removal of the nail and destruction of the matrix, and palliative include regular trimming of the affected nail by using the nail clipper or nail file or mechanical burr. Several cosmetics are used on the nail, which include the cosmetics cause alteration or damage of the nail and pterygium formation. Nail cosmetics can cause allergic contact dermatitis, and they are also an important supplement to dermatological management. Coatings that harden upon evaporation, that is nail polish. The nail liquid sometimes used to include enamel top coats and base coats. Reaction like allergic contact dermatitis can occur on the nail folds and also can occur on the eyelids because of the nail polish. On the face and the neck, nail plate staining occur by frequent use of the nail polish, and the nail are stained yellow or orange. Injury of nail plate from the nail liquid is rare, and several chemicals include formaldehyde, nickel, colpophony, resins, etc. Nail polish removers are solvents which cause excessive drying of the nail plate and some inflammation of the nail fold. The nail hardeners. Nail keratin can be hardened by tissue fixatives such as formaldehyde. Nail changes caused by such hardeners, including pain, subungual hemorrhage, bluish discoloration, onycolysis, and allergic contact dermatitis. So it was a little long lecture, but I tried to complete the lecture in one go. So I would like to thank you for a patient listening and hope to see you next time with another edition of my lecture. Thank you and have a good day.